time permits, we can have discussion at the end of the session. Next talk is by Dr. Dalia. She is Associate Professor in Government TD Medical College, Alappuzha. She will be talking on glaucoma laser procedures, what you should know. Over to Dr. Dalia.
So good morning all of you. My topic is glaucoma laser procedures, what you should know. The use of lasers in glaucoma has made the task of treating glaucoma the treatment more simpler, but proper indication and use is mandatory. These are the glaucoma laser procedures. We will go through each and every one in a short brief. The most commonly done one is laser peripheral iridotomy, which is the most commonly used in angle closure diseases. Now the question is whether all primary angle closure suspects need to be treated. All PACS are not to progress to PAC or PACG. Therefore, only PACS patients at risk needs laser peripheral iridotomy. That is when they require a regular follow-up. It is not possible to give frequent dilatation for their retinal evaluation, positive provocative test, one-eyed, family history of PAC or PACG, fellow eye also. Whereas primary angle closures are more likely to progress to primary angle closure glaucomas, therefore LPI is beneficial in these patients. In PACG, LPI is beneficial to decrease the further subacute attacks. It acts by decreasing the pupillary block component of angle closure. There is no change in the mean IOP or diurnal variation in IOP. In neovascular glaucoma, it is contraindicated because this is likely to bleed and increase the inflammation. Non-pupillary block angle closures also, these are contraindicated. Nd:YAG laser alone or argon laser followed by Nd:YAG laser in thick iris is used. It is better done superiorly, but any peripheral 1/3 can be chosen with a crypt. Avoid 2 o'clock and 10 o'clock. The size of iridotomy adequately is 150 to 200 micrometer to prevent further subacute attacks. Next is laser trabeculoplasty, which can be used as an adjunct or replacement therapy in all these conditions. It induces mechanical effect by increasing the trabecular meshwork tension circumferentially, thus pulling the outer layers of trabecular meshwork, increase the outflow facility and decrease the IOP. That is, it works by the natural aqueous drainage system. These are the lasers used. Commonly one is argon laser trabeculoplasty and selective laser trabeculoplasty, where frequency double QC Nd:YAG laser is used. Indications: primary open angle glaucoma and ocular hypertension, where it can be used as an adjunct or first line treatment in non-compliant and those who are difficult to administer anti-glaucoma medication, pregnancy, who cannot undergo glaucoma filtration surgeries. Secondary open angle glaucomas like pseudoexfoliation, pigmentary glaucoma and uveitic glaucoma controlled with steroids, and the steroid induced component is coming into play. You can use this. It can also be used in primary angle closures after the iridotomy has opened up the ankle. Absolute contraindications are inadequate visualization of the angle structures, glaucoma associated with active uveitis, trauma, angle dysgenesis, and because of the potential chance for failure, the relative contraindications are normal tension glaucoma, aphakia, and primary angle closure glaucoma, where there is extensive peripheral anterior synecdoche. In selective laser trabeculoplasty, there is selective photothermolysis which targets the pigmented trabecular meshwork. The advantage over argon laser trabeculoplasty is the energy used is less than 1%, and it is used for a shorter duration of less than 3 nanoseconds. Hence, minimum collateral damage is produced. A 360-degree selective trabeculoplasty causes a reduction of 30% reduction. In heavily pigmented trab, you can do 180-degree first and the remaining later if required. There is no significant reduction in the IOP fluctuation by SLT. Another type is micropulse diode laser trabeculoplasty, where you use low irradiance with larger spot size of 400 micrometer. The relaxation time between the micropulses helps return of the temperature to the baseline, hence no observable coagulative damage. Hence, while doing the laser, the endpoint is not like seeing cavitation bubbles as you see in ALT and SLT, and it is mainly dependent upon the operator skill and judgment. There are no reported post-laser complications, and in heavily pigmented traps, this MDLT is better than SLT because of the risk of higher risk of IOP, post-laser IOP spike. Now, next procedure is laser peripheral iridoplasty, where use low energy, low duration, larger spot size burns which are given to the peripheral iris to widen the angle and to break the peripheral anterior synechiae. It acts by heat shrinkage of the collagen and also contraction of the fibroblastic membrane at the region of laser application. These are the lasers which are used. It is used for controlling acute attack of angle closure, and that is the most common indication, which is unresponsive to anti-glaucoma medications, or when corneal edema, marked inflammation or shallow AC limits doing LPI, and also unresponsive attack even after patent LPI. In PACG, to open up an appositionally closed angle in plateau iris syndrome, and as an initial treatment in phacomorphic angle closure glaucomas, this can be used. If there is no visibility of the iris, as you see in the picture, due to corneal edema, opacity of flat anterior chamber, this is contraindicated, and these are the complications. But the long-term efficacy of this procedure is controversial, and also recurrence of appositional closure, which is requiring further treatment, is also seen. Next is laser cyclophotocoagulation, which is a current method of cyclodestruction, and which is more efficient and tolerated than cyclocryotherapy. Commonly used as diode laser. The various theories of mechanism of action are destruction of the ciliary epithelium and destruction of the ciliary blood vessels, leading to coagulative necrosis, ciliary body ischemia, and decreased aqueous protection. The intraocular inflammation also produces a short-term reduction in the IOP, and also it increases the uveous scleral outflow. Even though it was previously used for refractory glaucomas alone, now the indications have extended from end-stage glaucomas to patients with good vision, as in all these indications, especially pediatric glaucoma, multiple failed filtration surgeries, and also to relieve the pain in a painful blind eye. Different types of transscleral CPC, we use a G probe, and here there is extensive tissue disruption on either side up to pars plana and the iris stroma. In micropulse transscleral CPC, short repetitive pulses of diode laser are given, so more focal energy will be given to the non-pigmented ciliary body epithelium, hence the collateral tissue damage is also minimal. In endocyclophotocoagulation, the probe is directed onto the ciliary body epithelium. It can be combined with other minimally invasive glaucoma procedures, and also here there is no coagulative changes beyond the ciliary process as it is directly directed to that. In laser suturolysis, that's the next procedure which is done after trabeculectomy, where a tight scleral fab suture can be cut through the overlying conjunctiva. In the picture you can see the laser which has cut the second picture shows the laser which has cut the suture. Argon, frequency double ND-AG and diodes are used. It can be done in the early post-operative period, but when antimetabolites are used, the procedure can be delayed by 2 to 3 weeks or more. These are the complications like conjunctival perforation, flat anterior chamber, hyphema, blood leak, and malignant glaucoma. In iridolendicular synechiolisis, where the indication is occlusio pupillae to bypass the pupillary block of aqueous, the pupil for this procedure is tried to be dilated with mydriatics. Even though it may not dilate, it will stretch the area, hence the procedure can be easily done. The laser used is ND-AG laser with minimum energy. The plasma generated will sweep off the synechiae. Always start the procedure from 6 o'clock and then proceed upward on either side. Overfiltration or certain chronic blebs which may overhang on the nasal and temporal aspect. As you see in this picture, it can lead on to hypotony, irritation, cosmetic blemish, and Dellen on the adjacent cornea. Here, photocoagulative laser can be used. You paint the conjunctiva with gentian violet, and application of photocoagulative laser over the bleb will cause shrinkage of the bleb, and overhanging can be reduced. Next procedure is laser hyaloidotomy or the vitreolysis. The indications are malignant glaucoma in aphakic and pseudophakic eyes, which is refractory to the medical therapy. ND-AG laser is used, and with this you do a laser peripheral iridotomy with posterior capsulotomy and anterior hyaloidotomy, thus producing a direct communication of aqueous between the anterior chamber and the vitreous cavity. And you can see a slight deepening of the anterior chamber within 24 hours of the procedure. The relapse rate may be high, leading surgical options. So the take-home messages are: laser procedures in glaucoma helps reduction in IOP and better angle control by directing treatment to the predisposing factors itself. It can be used as first line or adjunct to anti-glaucoma medications or other surgical procedures. It is safe, effective, and quick, but proper indication, selection, and use of procedure is mandatory for a better outcome. Thank you.
Thank you, Dr. Dalia.